Welcome to the Radiographics podcast. I'm Wende Gibbs. This week, my co-host Frederick will summarize an important update on GI bleeding on CTA and CT enterography from the special body imaging monograph that's out this month. I'll give you an update on imaging and intervention for metastatic breast cancer. Since Dr. Frederick's article has vital information that any of us might see on call this weekend, let's start with that.
Gastrointestinal bleeding at CT angiography and CT enterography. Imaging atlas and glossary of terms. GI bleeding is a common, potentially life-threatening condition that we often see when we're on call. Locating the source of bleeding can be challenging and often requires coordination between different disciplines and evaluation with endoscopic and imaging techniques. CT can aid in identifying the location and cause of bleeding and is an important complementary tool to endoscopy, nuclear medicine, and angiography in evaluating patients with GI bleeds. For radiologists, interpreting CT scans in patients with GI bleeds can be challenging due to the large number of images and the diverse potential causes of bleeding. According to the authors, the purpose of this article is to provide a practical resource for radiologists interpreting CT in patients with GI bleeding to facilitate standardized exam interpretation and improve the clarity and clinical impact of radiology reports. So let's review the clinical terminology for the types of GI bleeding. Upper GI bleeds originate proximal to the ligament of Treitz, whereas lower GI bleeds originate distal to the ligament of Treitz. Small bowel bleeding originates distal to the ampulla of Vater and proximal to the ileocecal valve. Suspected small bowel bleeding is that in which no source is identified after performing both upper and lower endoscopy. Overt GI bleeds are evident clinically in the form of hematemesis, hematochezia, or melena. The term overt GI bleeding is preferred over acute because acute implies that the rate of the patient's symptom onset or how they presented and does not necessarily describe the visibility of bleeding. Occult GI bleeds are not clinically visible and present with a positive fecal occult blood test or iron deficiency anemia. Obscure GI bleeds are those in which no bleeding source is identified after the entire GI tract has been comprehensively evaluated with advanced endoscopic and imaging techniques. These can be either overt or occult. Once the likely location of bleeding has been determined, the radiologist may be able to narrow the list of diagnostic possibilities on the basis of the patient's history and risk factors for GI bleeding. Relevant history includes the type of GI bleed, associated signs and symptoms, contributing event such as trauma, vomiting, or hypotension, and recent procedures. When CT is performed for patients with GI bleeding, the goal of the examination depends on patient history. For patients with overt GI bleeding, the goal of CT is to identify intraluminal blood, contrast extravasation, and/or the cause of bleeding. For occult GI or suspected small bowel bleeding, since there is a slower bleeding rate, the goal of CT is typically to identify the cause of bleeding rather than subtle contrast extravasation. Because of these different goals, many centers use two different CT protocols, one for overt GI bleeding and another for occult GI or suspected small bowel bleeding. For the evaluation of overt GI bleeding, most centers use a multi-phase CT technique including non-contrast, late arterial, and venous phase images. I'm sure by now y'all are just dying to hear the CT signs of GI bleeding. On non-contrast CT, high attenuation intraluminal fluid may be a sign of active bleeding in this portion of the bowel. The attenuation of usual intestinal contents in the bowel lumen generally approaches that of simple fluid. Unclotted blood has attenuation of 30 to 45 Hounsfield units, and clotted blood has attenuation of 45 to 70 Hounsfield units. At CT, a sentinel clot refers to acutely clotted blood, which appears hyperattenuating and may be located closest to the bleeding site, whereas lower attenuation unclotted blood may be located farther from the source. Active GI bleeding is depicted by the accumulation of extravasated contrast material in the bowel lumen as a focus, jet, cloud, or blush of variable size, usually appearing during the arterial phase. Contrast extravasation generally changes in size, shape, attenuation, and location on later phase images and usually moves downstream. An enhancing focus that changes in attenuation but not shape on later phase images may be a vascular lesion. The absence of hyperattenuating material on non-contrast images at the site of possible extravasation on post-contrast images helps to confirm active bleeding. Active extravasation may also be seen exclusively in the venous phase, resulting from venous bleeding, or less likely, slower or low volume arterial bleeding. Finally, the absence of arterial phase extravasation does not imply a negative CTA exam until it is confirmed to be absent during the venous phase. The most common CT pitfall that mimics active contrast extravasation is the presence of hyperattenuating material within bowel loops, most frequently hyperattenuating colonic fecal material, retained or inadvertently administered positive oral contrast agent, or prior pill ingestion. Every hyperattenuating focus suspicious for active bleeding on contrast-enhanced images must be confirmed to be absent on non-contrast images. Foreign bodies include feeding tubes, surgical drains, stents, embolic material, and surgical sutures or clips may not only be mistaken for active extravasation, but may also obscure areas of bleeding. Other causes that may be mistaken for active hemorrhage include mucosal hyperenhancement of normal collapsed bowel segments, hyperattenuation of the diseased bowel wall, hypervascular masses, and vascular lesions. Let's review some of the causes of GI bleeding, starting with upper GI bleeds. The most common causes of upper GI bleeds are peptic ulcer disease, as well as mucosal erosive disease involving the esophagus, stomach, or duodenum. Direct signs of peptic ulcer disease include a focal outpouching and a mucosal enhancement defect. Indirect signs include gastric or duodenal wall thickening, submucosal edema, mucosal hyperenhancement, adjacent stranding, and signs of perforation. CT findings of esophagitis include circumferential esophageal wall thickening, mucosal hyperenhancement, and submucosal edema. Gastroesophageal varices usually result from portal hypertension in the setting of cirrhosis. On CT, gastroesophageal varices appear as enhancing foci or tubular structures within the distal esophageal or stomach wall that follow blood pool attenuation on all phases. Esophageal, gastric, and duodenal cancers can all ulcerate and cause GI bleeding. Esophageal cancers can show asymmetric or marked focal wall thickening, often with paraesophageal lymph nodes. Gastric cancer can produce focal or diffuse gastric wall thickening or manifest as an intraluminal polypoid lesion and can be associated with perigastric lymph nodes, liver and lung mets, and peritoneal disease. Gastric lymphoma can manifest as focal or diffuse wall thickening, an ulcerated mass, or polypoid or nodular fold thickening. Gastric metastatic disease can arise from melanoma, breast cancer, or lung cancer. Gastrointestinal stromal tumor, the most common GI tract mesenchymal tumor, most commonly arises in the stomach and small intestine. These tumors are commonly exophytic and can ulcerate. Doulophoid lesions are submucosal arteries that erode through a small GI tract mucosal defect and can rupture, resulting in severe bleeding. Most occur in the proximal stomach, usually along the lesser curvature. On CT, doulophoid lesions show a nidus of arterial phase enhancement and are not as well seen on subsequent enteric or venous phase images. GI bleeding can occur as an early or late complication of bariatric Roux-en-Y gastric bypass surgery. Early bleeding can occur at the gastric pouch or gastric remnant staple line, or the gastrojejunostomy or jejunojejunostomy anastomoses. A common cause of late GI bleeding is marginal ulceration near the gastrojejunostomy site. Let's discuss lower GI bleeds. The most common cause by a long shot is diverticulosis, typically manifesting as painless hematochezia. The CTA hallmark of diverticular bleeding is contrast extravasation into a colonic diverticulum that appears on arterial phase images and changes in size, attenuation, shape, and location on delayed phase images. Colonic ischemia most commonly results from a sudden decrease in mesenteric perfusion caused by a low flow state. Less commonly, colonic ischemia can result from arterial occlusion or mesenteric venous thrombosis. Most colonic ischemia cases occur in elderly patients and classically occur in the colonic watershed areas, the splenic flexure and the rectosigmoid junction. The rectum is typically spared from ischemia due to its dual splanchnic and systemic arterial blood supply. While the CT appearance of colonic ischemia overlaps with those of other causes of colitis, the pattern of involvement in conjunction with the clinical history helps with the diagnosis. The CT findings depend on disease severity and duration and whether reperfusion has taken place, and can include bowel wall thickening, mucosal hypo or hyperattenuation, abnormal mural enhancement, pericolonic stranding, and free fluid. Pneumatosis or portovenous gas may occur when there is bowel infarction. Hemorrhoids are a dilated arteriovenous plexus arising from the superior and inferior hemorrhoidal veins. On CT, hemorrhoids appear as enlarged serpiginous veins within the anus and lower rectum that are best defined on portovenous phase. Other causes of lower GI bleed include colorectal neoplasm, recent colonic polypectomy, and angioectasia. Now let's cover small bowel bleeding, which accounts for 5 to 10% of GI bleeds. They often manifest as obscure GI bleeds. Common causes in patients younger than 40 include inflammatory bowel disease and Meckel diverticulum. Common causes in patients older than 40 include angioectasia and NSAID enteropathy. Common to all age groups are neoplasm and Dieulafoy lesions. When patients with Crohn's disease present with overt lower GI bleeding, diagnosing the site of bleeding and patient treatment can be challenging because it can involve multiple bowel segments, any of which can be the site of bleeding, and active bleeding may have stopped at the time of scanning. Furthermore, the presence of strictures may preclude endoscopic evaluation. NSAIDs may result in bowel injury with erosions, ulceration, and stricturing. At cross-sectional imaging, the hallmark of NSAID enteropathy is multiple short segment or diaphragm-like strictures that tend to be clustered within the same region or segment of the bowel, usually in the ileum. The diaphragm-like strictures are circumferential and short. The wall associated with the strictures is typically thickened and hyperenhancing. Angioectasia, the most common cause of small bowel bleeding, is more common in older patients. On CT, angioectasias appear as nodular or discoid foci of enhancement in the bowel wall, or focal ectasia of the intramural veins, best seen on venous phase. Alright, let's recap a few key points. Active GI bleeding is depicted by the accumulation of extravasated contrast material in the bowel lumen as a focus, jet, cloud, or blush of variable size, usually appearing during the arterial phase. Contrast extravasation generally changes in size, shape, attenuation, and location on later phase images, and usually moves downstream. An enhancing focus that changes in attenuation, but does not change shape on later phase images, may be a vascular lesion. The absence of hyperattenuating material on non-contrast images in the same location of possible contrast extravasation on post-contrast images helps to confirm active bleeding. The most common CT pitfall that mimics active contrast extravasation is the presence of hyperattenuating material within bowel loops, most frequently hyperattenuating colonic fecal material, retained or inadvertently administered positive oral contrast agent, or prior pill ingestion.
That was great information. Thank you, Ross. This can be very difficult and frightening, especially cases of potentially life-threatening bleeding. Knowing the many potential causes of bleeding and what they look like is so important, and this atlas is a great resource for emergency radiologists, anyone who takes call, really all of us. Okay, so let's move to the update on breast cancer. Imaging updates to breast cancer lymph node management. In patients with breast cancer, the presence and extent of lymph node metastasis is a key factor in patient outcome and survival. This used to be determined by findings at surgery, and based on these findings, the adjuvant treatments were determined. But a big advance in this field has been the increasing application of neoadjuvant systemic treatments, which are being used as initial treatments. So for example, Cases that respond well to medical therapy may allow for a less radical surgery. As this has evolved, radiologic staging has become more and more important. Neoadjuvant therapy is commonly used for inflammatory breast cancers, biologically aggressive triple-negative and HER2-positive cancers, and locally advanced cancers with extensive breast or regional nodal basin involvement. For the chemosensitive malignancies, drug therapies may result in a pathologic complete response in 31 to 57% of cancers. That's in the breast, and 45% of lymph node metastases. This can result in downstaging of both the tumor and nodal involvement. Imaging during and after completion of neoadjuvant therapy can be performed to monitor and assess the in vivo response, thereby allowing opportunities to tailor the chemotherapy regimen and test new drug therapies. In this field, like all areas of oncology, a multidisciplinary approach increases efficiency and optimizes patient care. Imaging and image-guided lymph node interventions have become an important part of assessment. We can evaluate all regional nodal basins with imaging, including locations where surgery is not usually performed. By differentiating limited versus extensive nodal involvement, these findings help determine whether initial treatment should be surgical or medical. If the decision is made for medical treatment with neoadjuvant treatment, imaging is performed to monitor the in vivo nodal response to drug therapy and ultimately to help determine the best surgical technique based on the final imaging findings after the neoadjuvant treatment. In this paper, the authors discuss the imaging features of nodal metastases and the indications and techniques for the various image-guided procedures. They review the relative usefulness and shortcomings of the various imaging examinations and discuss how they can be applied when biopsy results are not available. The paper starts with a detailed description of lymph node anatomy and the pathologic process of increasing metastatic involvement. I may have learned this in medical school but have forgotten, and maybe I've taken lymph nodes for granted. This is really an interesting part of this paper. A normal lymph node has an oval or reniform shape with central fatty hilum and a thin outer cortex, with a long axis-short axis ratio greater than 2. Lymphatic flow enters the cortex through the afferent channel and then exits the hilum through the efferent channel. As tumor cells deposit and coalesce near the marginal sinus, the cortex progressively thickens. There's a classification of lymph node morphology based on the cortical-hilar relationship, so we can objectively categorize the variable appearance of pathologic lymph nodes and the corresponding likelihood of malignancy. The proposed classification has been validated by other studies that have stressed that cortical thickening greater than 3 millimeters and absence of a fatty hilum are more accurate indicators of malignancy than the overall size of the node. I'm pretty sure this applies to all lymph nodes in the body. Take a look at the paper online or in the print journal to see examples of the different stages of lymph node infiltration with tumor cells. The 8th edition of the American Joint Commission on Cancer Staging, AJCC, staging manual introduced a new prognostic staging group based on the anatomic TNM stage and tumor biology parameters, including grade, biomarkers, and multi-gene assays. The multi-gene assays estimate risk of recurrence and are used to determine if chemotherapy is likely to be beneficial. The changes to the AJCC staging manual emphasize the heterogeneity of breast cancer biology and the importance of individualized treatment. The anatomic, pathologic TNM staging system has remained unchanged from earlier versions. The N classification is determined by the location, size, and quantity of lymph node metastases. The margins of the pectoralis minor muscle divide the axilla into levels 1, 2, and 3. While surgical dissection can address nodal metastases that involve the level 1 and 2 axilla, adjuvant therapies are often required to treat disease involving the level 3 axilla, which is infraclavicular, the internal mammary, and supraclavicular regions. Ultrasound is the primary imaging modality used for nodal staging. Ultrasound is widely available and well tolerated by all patients. The main advantage of ultrasound is its ability to guide biopsy. The small footprint of the high-frequency linear transducer permits imaging of the entire regional nodal basins, including regions that may not be included in standard breast MRI or surgery. We can better appreciate the morphology of the nodes on ultrasound than with other modalities, and can detect metastatic deposits greater than 5 millimeters. The main limitation of ultrasound is the operator-dependent subjective nature of image acquisition, so you need good staff training and experience. If a facility lacks consistent availability of trained sonographers, radiologists, and/or pathologists, there may be less benefit for ultrasound for biopsy and staging. Ultrasound combined with fine needle aspiration has been shown to be consistently accurate and clinically useful. It helps determine the initial treatment choice between surgical sentinel node lymph node biopsy and medical, non-surgical neoadjuvant treatment because it can help identify extensive nodal disease, for example, N2 and N3 disease. Most important, performing ultrasound-guided FNA biopsy is possible in more than 90% of ultrasound-detected lymph nodes and can expedite care by providing tissue confirmation of suspicious nodes. How about the other modalities? The combination of various cross-sectional imaging modalities, as well as serial imaging before and after neoadjuvant therapy, may be used to guide management decisions in select cases in which biopsy results are unavailable or in cases in which imaging findings are in disagreement with each other. These special circumstances may indicate the need for further evaluation with MRI, PET-CT, as use of multiple imaging modalities improves both the sensitivity and specificity of nodal metastases. MRI, PET, and chest CT are less operator-dependent than ultrasound and demonstrate the pectoralis minor muscle, clavicle, and intercostal spaces that can be cross-referenced on different planes to help place a suspicious node accurately into its anatomic location. The major limitations of these modalities are inconsistent use among breast cancer cases, cost, and inability to proceed directly to biopsy. When suspicious lymph nodes are detected, targeted second-look ultrasound is commonly performed in an attempt to identify a sonographic correlate for an ultrasound-guided biopsy. This two-step process adds to potential delays in treatment. Briefly on the role of imaging in lymph node spread patterns. Historically, axillary lymph node dissection was performed in all invasive breast cancers, but this is no longer the case. De-escalation of surgery and neoadjuvant treatments are more often performed now. Sentinel lymph node biopsy is performed in cases of limited nodal involvement and relies on an orderly progressive pattern of nodal metastases. If axillary lymph node dissection is indicated, routine surgical dissection is usually limited to the level 1 and level 2 axillary nodes. Per NCCN guidelines, surgical dissection of the level 3 axilla is reserved for cases with gross level 2 disease and/or level 3 disease at the discretion of the multidisciplinary team, as alternative treatment options with radiation therapy and systemic therapy may be used instead. Similarly, internal mammillary and supraclavicular nodal metastases are often treated with a combination of targeted radiation therapy and systemic therapy, with surgery only rarely performed in these regions. As surgery is not often performed in these regions, and in the 7% of nodal metastases that can spread in a skip, non-aggressive manner to the supraclavicular and level 3 axilla, imaging is necessary to detect the full extent of nodal disease. Now, I won't go into this next part too much for the sake of time, but read the section on targeted axillary dissection and node localization. The surgical removal of the clipped metastatic node, along with the sentinel nodes, is known as targeted axillary dissection. In 23% of lymph node mapping procedures, the biopsy-proven clipped metastatic node does not correspond to one of the sentinel nodes. As a result, performing sentinel lymph node biopsy alone would result in an unacceptably high false negative rate. To ensure surgical resection of the metastatic node, a clip is placed into the hypoechoic thickened cortex of a suspicious level 1 node immediately following core or FNA biopsy. The hyperechoic clip and its depth from the overlying skin then serve as the landmark for localization if the node normalizes after chemotherapy. Different clips have variable visibility on ultrasound, with greater visibility noted in some of the larger clips. And they have great pictures of these in the article. Take a look. Very interesting. So in summary, imaging is used to determine treatment approach, as multiple studies have demonstrated that ultrasound findings correlate with the extent and number of nodal metastases found at surgery. Use of ultrasound with biopsy to stage metastatic nodal involvement can reduce the number of inappropriate sentinel lymph node biopsy surgeries by 14 to 20%. Ultrasound with biopsy helps define treatment by determining the extent of nodal metastases. If there's limited nodal disease, the patient is usually offered surgical sentinel lymph node biopsy. However, if there's extensive nodal disease, either medical neoadjuvant systemic therapy or axillary lymph node dissection is generally recommended. If the initial treatment is neoadjuvant systemic therapy, imaging is next used to assess the in vivo response to drug therapies, which has been shown to be dependent on the breast cancer subtype. Finally, after treatment, while none of the imaging modalities are accurate enough to preclude surgical axillary staging after neoadjuvant systemic therapy, They can be used to triage the good responders to targeted axillary dissection and poor responders to axillary lymph node dissection. All right, that's a lot of new information. Check out these papers and so much more in this month's journal and the special body imaging monograph. And join us again in 2 weeks for more summaries.